Good afternoon and welcome to this meeting of the Overview and Scrutiny Committee on Wednesday, the 19th of January 2022. This is taking place in the Spark and Hoe Committee Room here at County Hall in Glenfield. Some officers will be joining online via Teams. This meeting is being webcast live to the public on YouTube, so please turn off your microphones when you are not speaking and turn them on when you are speaking. So we've got a full agenda today, so I'm going to get straight on into it. Agenda item 1, which is the minutes of the meeting held on the 10th of November 2021. I propose that the minutes of the meeting held on the 10th of November are taken as read, confirmed and signed. Is everyone agreed? Agreed? Thank you very much. Item 2 is question time, and we haven't received any questions from the public, so that takes us on to item 3, which is questions asked by members under Standing Order 7.3 and 7.5. I have received 2 questions from Stuart Bray regarding dental practices. Mr. Bray has been provided with the answers to the questions, and the answers have been circulated to members and published on the website. Mr. Bray, do you wish to ask any supplementary questions?
No, thank you, Chairman. Thanks for the answers.
Thank you very much. So that means we move on to item 4, which is to advise of any other items which the Chair has decided to take as urgent elsewhere on the agenda, and there are no urgent items. It leads us on to item 5, declarations of interest in respect of items on the agenda. So can I ask members whether there are any items or declarations that they need to make? Mr. King.
Yes, Chairman, just to declare that I am a member of the Leicestershire Rutland Carers Centre, and also that for the absolute avoidance of doubt, my wife is employed by a charity that deals with supporting people who are recovering from strokes, but that is in the city, not in the county, but just for the avoidance of doubt.
Thank you. Can I just check, are those in relation to any particular agenda item, or is that just a general interest?
Well, I think there is, that would be in particular related to the health and wellbeing strategy, but yeah, thank you. Should scare us in the report.
Thank you very much. Are there any other declarations that anyone wishes to make? Ms. Sack.
Thank you, Chair. Just a regular declaration. I work for Advanced Housing, which provides accommodation for people with learning disabilities and mental health conditions in the county of Leicestershire.
Thank you very much. Okay, I can't see any other declarations, so we now move on to item 6, with declarations of the party whip in accordance with Overview and Scrutiny Procedure 16. I'm taking that there are no declarations of party whip. I'm looking around the room, though there are no declarations. So we now move on to the item 7, which is the presentation of petitions under Standing Order 35. We have received a petition from Mrs. Hack, Amanda Hack, relating to the Forest House Medical Centre's proposal to close its Park Drive surgery. The precise wording of the petition is set out on your agenda. At the time of publishing this agenda, the petition had attracted 1,284 signatures. Mrs. Hack would like to say a few words regarding the petition. So over to you, Mrs. Hack.
Thank you, Chair. And I've got my colleague, Councillor Bob Waterton, with me too, who may will want to say something as well. Thank you for the opportunity to present this petition, say Forest House Medical Practice, to Health Scrutiny today. As indicated on the agenda, this petition is signed by more than 1,280 people, a clear reflection of the strength of local opposition to this impending closure. During my regular conversations with residents, it became clear that the consultation on the relocation of Forest House Medical Practice, which is on the Brawnston Crossroads, to a new facility in Lubbersthorpe had been poorly communicated. As well as some saying they didn't know it was going to close, others said that the consultation questions didn't allow them to fully engage with the process. One elderly lady told me the decision they felt had already been made. It doesn't really matter what we say. Another person said that they feel that they're using COVID as an excuse to wind down services at Forest House Medical. The consultation undertaken by the practice themselves and failed to acknowledge that the closure would prove a major headache for some residents in the surgery's catchment area, particularly those who live in Brawnston Town, Leicester Forest East and some that live in Thorpe Astley. The consultation failed to ask where people lived, making it impossible for them to understand the needs of the community as a whole. Furthermore, the consultation didn't investigate the time spent accessing GP services by specific patient cohorts either, so it didn't link to anybody with a vulnerability or a disability. So there's been no clear understanding of who needs the services, what they need, where and for how long. In addition, the report that went to the CCG Common Board suggested that nearly half of the consultation respondents thought that travel distances would be problematic for them, but yet no meaningful mitigation was offered. The answer I received on the 26th of December to my direct question to this body on the 1st of September said the responsibility was with Leicestershire County Council and that the practice had tried to engage in meaningful discussion with Highways but without success. So I've checked with Highways and they actually referred the matter to the organisation undertaking the transport work for Lubbersthorpe. So they did engage, and I think that was fair for them to say. So the practice has plans to close a facility, which will cause a major problem for one part of their catchment, but the transport mitigation measures required to be passed to somebody else. Passed to a body that actually has no responsibility for the transport needs of people who live outside of Lubbersthorpe. So it doesn't consider those who live in Braunstone Town or LFE or Thorpe Astley. The people who will be penalised most by this ill-considered closures have actually not been consulted very well at all. Finally, before I pass on over to my colleague Bob Waterton, the Town Councillor for Winstanley, one of the key people that have led the petition, I'd just like to stress that this closure feels like very real health needs of patients living in the well-established community that is Braunstone, my division, have been sidelined at the expense of the new community of Lubbersthorpe, leaving a huge gap in services. No case has been made to maintain both services. The focus on the practice is of that of the new, nice, shiny building. This is of no comfort to residents who can't get there without considerable cost and inconvenience. I urge CCG to show some respect for both the views that have been expressed in the petition and, more importantly, the healthcare needs of people living locally in Braunstone Town and Leicester Forest East. It's a bad decision and one that's bad for the health and well-being of the people that I serve. I urge them to review their decision and make a proper structured assessment of the patient needs in all parts of their catchment. Thank you, Chair.
Thank you very much, Amanda. So, Bob, I think you've been referenced by Amanda. Would you like to say some words as well?
Yes, thank you very much, Chair. You can hear me now. Yeah, the first word I suppose I'd like to use is overwhelming, because it's not just the numbers, about which I might say a few more words in a moment, but it was the unanimity and the anger and the willingness to sign of the people that we spoke to. I did a lot of door knocking to collect signatures, and the opposition to the proposed move was very powerful. This is a petition is a genuine public view, and I hope it will not be dismissed by anyone. The petitioners and their locality, as Councillor Hack has said, were poorly served by the surgery's own consultation exercise. And we constantly found, when we were knocking on doors, that people had not received the paper version, and many people still are in a position where they're not able to go online. And as far as I know, Chair, it is also the case that the CCG has not carried out its own consultation exercise on this important issue before making its decision. And that too is a matter of concern. On the actual proposal, as Councillor Hack's demonstrated, the proposal to close Forest House Medical Centre on Braunstone Crossroads and move it to the Lubbersthorpe estate has not been well thought out. The proposal represents a loss of NHS provision to a large swathe of the population of Braunstone Town, Leicester Forest East, Kirby Muxloe, and to an extent Leicester City, because we have to remember that Braunstone Lane has two sides to it, and the other side of it is Leicester City. And there are many elderly people there who will use the services of Forest House Medical Centre. we received signatures from people across that broad swathe, although the initial focus was on Bronson Town's Winstanley ward. Time and resources didn't permit us to maximise these signatures, but in my view, had we been able, we may well have been able to double or treble the number of signatures, and I think signatures are still coming in on change.org. Basically, the petitioners want a reconsideration. Otherwise, the NHS will be seen as removing services with no replacement, and thereby disadvantaging a large local population containing, as we found increasingly as we went around, many elderly and disabled people and many families on low income. Anyone looking at the geography as well and the logistics and the possible transport options will see immediately that transport is not a solution to the problem of the big hole in NHS services which will be created by this proposed move. We're quite sure that the CCG and the NHS will not want to be seen as the bringer of disadvantage to a large local population. And so on behalf of the petitioners, we urge the CCG to reconsider. Thank you, Chair.
Thank you very much, Councillor. As what the petitioners are asking is not directly within the control of this committee, I propose to write to the Clinical Commissioning Group to make them aware of the petition and ask the CCG to respond to the issues raised by the petition as part of an agenda item at the next meeting of the committee on the 2nd of March. Is everyone in agreement with this? Okay, thank you very much. Okay, thank you very much, Amanda, and thank you very much, Bob, as well. So we move on to item 8. We've had 3 substantial items on the agenda. We are aiming for the meeting to conclude by 4 o'clock. So if people could direct their questions to the items that we're discussing, and obviously try and draw out the best part of the debate from doing so. And as always, we will take the papers as read, but I will ask each of the presenters to do a very short summary, just pulling out the items that they've wished to identify with more significantly than others. So we move on to item 8, which is the draft Leicestershire Joint Health and Wellbeing Strategy. We've got with us, and this is actually for a 10-year period, so this is actually 2022 to 2023, and it is on pages 15 to 52 of your agenda pack. We are joined by the chairman of the Children and Family Scrutiny Committee and also the Adults and Communities Scrutiny Committee. So welcome to Mr. Fry and also to Mr. Richardson. Thank you very much for joining us. We also have, I think, Viv Robbins online. Are you there, Viv? Yes, you are. Who's our consultant in public health. And also, obviously, we've got Mike Sandys, who's our Director of Public Health, in the room with us. So first, Mike, can I ask you possibly to say a few words to introduce this item? As I said, we're going to take the information as read, but otherwise, if there's anything that you wish to draw out.
Yeah, thank you, Chair. I should start by saying, as Mrs. Hack knows, Mr. Waterton was actually one of my lecturers on my first degree in economics, so I should feel that I should be making notes. But there we go. Anyway, as you were saying, so the purpose of this report is to bring to the committee the draft health and wellbeing strategy for 2022 to 2032. Not the first strategy that the Health and Wellbeing Board has put together, but for reasons I'll maybe just hand over to Viv to do a quick summary. I know the paper will be read. I think it really, to my mind, is probably the more important one that we've done so far, not least of which to developments around the ICS. But I think that's it from me. I will just maybe give Viv opportunity for a minute just to summarise the key bits.
Over to you, Viv.
Thank you, Chair. So thank you everyone for allowing us to come today and just summarise where we are in terms of the Leicestershire Joint Health and Wellbeing Strategy. So just a bit of background in terms of where this has come from. So the Joint Health and Wellbeing Strategy is a statutory requirement of the Health and Wellbeing Board, and we have had agreement around aligning the Joint Health and Wellbeing Strategy with the Integrated Care System requirement to develop a place-led plan. So you may hear the terminology changed in different ways, but basically the vision is around the Joint Health and Wellbeing Strategy, and then the delivery plan that will be developed alongside this will be the place-led plan, which will give us basically one clear vision for Leicestershire around how we can really drive those improvements around health and wellbeing and care across Leicestershire. Just to put a bit of background in terms of how this has come together, so just to reassure partners that this is really taking a collaborative approach, really cross-referencing a range of partners in terms of the development of this approach, and the draft priorities that you've got in the strategy today have come from a Health and Wellbeing Board development session, which was based on a very thorough needs assessment slide deck. So just to provide some reassurance there. In terms of the overarching priorities, I'd just like to draw your attention to there's a diagram on page 29 of your report, figure 4, which is almost, I suppose, the plan on a page in terms of the overall summary of the strategy. So our overall vision is giving everyone in Leicestershire the opportunity to thrive and have happy, healthy lives. And we've taken the life course approach, as you can see from the sort of roadmap on the diagram there. So we've got the 4 life course areas that are aligned with the ICS priorities around best start for life, staying healthy, safe and well, living and supported well, and then dying well. And you can see there's some key priority areas there. And I won't go into the detail because I appreciate we're get into some questions around those. And then we've got some cross-cutting themes in terms of mental health, reducing health inequalities, and the impact or COVID recovery work that we will be progressing moving forward. And really acknowledging that these will be areas that will be linked into all areas of those life course. So really making sure that they are cross-cutting themes around that. The areas that we talk about on the bottom are basically the enablers, or what we think that we need to surround the strategy, or some of the ethos around the strategy in terms of how we will progress some of that moving forward. And keen to get your thoughts on what you think in terms of the detail of the priority and how we can move these forward from yourselves. In terms of how we're sort of delivering the strategy and how we're aiming to get ownership and real buy-in and delivery of that. As I said, this will be a responsibility of the Health and Wellbeing Board, and we're really keen to look at how we evolve the Health and Wellbeing Board. There's done some great work so far, and it's how we can take it to that next level, really acknowledging the opportunities that we've got with the integrated care system coming on board, and a lot more statutory responsibility from our NHS partners around some of those health inequalities and wider prevention agenda items, which are real opportunities and a real change, I suppose, in terms of appetite and drive for some of those areas, which is a great opportunity for us. So one of the things that we will be doing in terms of the Health and Wellbeing Board, and it will come with a range of papers that are coming to the Health and Wellbeing Board in February, which will include the final version of this strategy and delivery plan, is really looking at how we can evolve the approach of the Health and Wellbeing Board using a sort of do, sponsor, watch approach to help prioritise areas of the board that the board really wants to spotlight on, so we can have really constructive discussions around how we can move some of those really tricky areas around health and wellbeing forward for Leicestershire. We do acknowledge that this strategy is almost an umbrella strategy, and there are lots of other really fantastic pieces of work and strategies across Leicestershire that will almost hang underneath these and will be part of the delivery of the work. So I know recently there's been work around the County Council's strategic plan, for example, but there's quite a lot of wider ICS strategies that will link into this, as well as Leicestershire specifically. And the other thing just to highlight is that there will be some work looking at the Health and Wellbeing Board subgroups in terms of how we make sure there's really clear implementation of this strategy, and looking at the terms of reference of the Health and Wellbeing Board to make sure they're reflective in terms of where we want the board to go in the future, but also really considering the sort of communication and engagement approach that we want to really build that conversation with our local population in a slightly different way moving forward, that will hopefully build on the consultation that we've got going on at the moment. And obviously we will be reviewing the strategy on a regular basis. So there will be regular reviews of the delivery plan, annual reviews on progress, and then every 3 years we're going to do almost more of a deep dive review on the strategy, because we do acknowledge that things will change and evolve locally and nationally, that we will need to reflect in the wider 10-year strategy. So in terms of where we're at the moment, we're currently in an 8-week consultation period, and we're really keen to hear your views on the strategy itself. We would ask, there are links in the papers in terms of where you can access the consultation, and that's open till the 23rd of January. So I suppose that's really the key messages from me today. Just really keen to ask partners around the table to really let us know what your thoughts are, whether we're hitting the right mark on the strategy, but also really ask you to really support the consultation and circulate it as widely as possible as you can for us moving forward. So I'll leave it there. Thank you, Chair.
Thank you very much, Viv. That's a very good summary. Can I ask one quick question, actually? Bob, you're still up on our screen. Is it possible to actually turn your camera off? By all means, stay in with the meeting. Otherwise, we can see your reaction to everything that Viv was saying as well, which you probably didn't want us to see. If you just click your camera off and then perfect. There we go. Look, there we go. Fantastic. Then we can concentrate on one person on the screen. That's perfect. Thank you very much. Right. Can I open up for debate and questions? Phil, I think you had a question which I know you want to raise.
Okay, I'll just have to find it now. Okay. Sorry, in the health inequality. So thanks, Viv, for your comments. But in the section about health inequalities, one of the issues in Leicestershire is obviously accessibility to health care, and also to some of the things that will obviously impact on people's health and broader well-being. So, for example, affordable housing. So how that I can't see that being reflected in the report much at all. I just wonder if that can be in the final version, be looked at.
Yeah. Am I okay to come back on that, Chair?
Please do. Yes, absolutely.
Okay, thank you. So in terms of housing, we have got a priority area under the Staying Safe, Healthy, Safe and Well around building strong foundations. Within that, we've talked very much about having good homes. So there's something there around having good housing infrastructure in terms of the housing estate that we have got now, but also thinking around what housing that we're going to need in terms of moving that forward. And some of that particular pieces of work around the wider determinants are going to be coming through a new evolved subgroup of the Health and Wellbeing Board called the Staying Healthy Partnership. So I think there will be much more focus around some of those wider determinants, including housing and thinking about homelessness in that agenda as well, moving forward. So I can double check that and see if it's strengthened, but I'm hoping that it should be already included, but more than happy to pick up with you if you feel that we need to do more work on that.
Do you want to come back?
Okay, that opens up something else which I wasn't expecting. Just if I can just drill back to it was about rural inequalities. So in some of its sparsity issues, in large parts of the county, we've got very few people living. So accessibility to healthcare services, in particular, is quite challenging, if I can put it like that. And the other thing is, overall in the strategy, it talks about population demographics, and that's fine. But in parts of the county, you've got different demographic profiles. So, example, in Market Harborough, which I represent part of, we've got quite our largest population profile is probably older residents, whereas across the county it isn't that group. It's a younger age set, if I can put it like that. So I just wonder how that's going to be addressed. Is that going to be addressed in the action, the delivery plan, or is that how are you going to look at sort of ensure that doesn't get overlooked in the broader statement that you're making in the report? Thank you.
Thank you. If I'm all right to come back on that. So I think there's a two-prong approach, I think, to the health inequalities work. the Health and Wellbeing Board has already signed up to the LLR Health Inequalities framework, and so there are things in there around having health and equity in all policies, and almost having a health inequalities lens through all the work that we do. So there's something in there. But there's also something around thinking around what we need to do specifically for Leicestershire. So how we translate some of that health inequalities work for Leicestershire, and also how we think about how that translates to some of the community health and wellbeing plans. So we absolutely acknowledge that Leicestershire as a whole is a massive county, and we have lots of different needs in different areas or localities and or neighbourhoods within our Leicestershire as a whole. And underneath the joint health and wellbeing strategy, which is the overall vision, there are going to be a range. I think there's 7 community health and wellbeing plans that are going to be developed, and they will look at the much more granular detail. So we're making sure that there's real clear links between and sort of almost a golden thread between the overarching strategy for Leicestershire and then what's going to be coming out of the community health and wellbeing plans, to make sure that both link up and down and feed into each other there. So I'm hoping that sort of having that two-pronged approach will make sure that we do consider health inequalities, but absolutely acknowledging for Leicestershire that the rurality of Leicestershire is a significant health inequality that we will need to consider and push, particularly when we're working on a wider ICS basis.
Mike, you want to come in?
Yeah, it's just to follow on from that, Viv. I'm also thinking equity audits. So clearly we've done our own equity audit around access to services like health checks. It is one of the key principles in the health inequalities framework, which I know is an NHS document across LLR, but we will then follow those principles. If it's not in there, I suppose it's a comment and a prompt, which we just need to make certain the community wellbeing plans similarly look at their own equity audits around access to services, because I think you're right, health and all policies is in there, but we just need to make certain there's some detail around, let's look at this service, are people, because of the rurality or sparsity of services, being fairly served, and just making certain that's one of those key tools we push. Is your chance to agree with me at this point?
Yeah, no problem. That's fine. We can strengthen that. That's no problem.
Okay, Mr. King, Orbit.
Yeah, look, thanks for that. I appreciate it. I've got one further point which I can just want to raise at the moment. So one of the issues, just to say, there's lots of really good stuff here, but one of the issues is that clearly, and rightly so, a lot of focus on children, young people who have special educational needs and disability. Apart from the county council has a responsibility up to the age of 25. Now, speaking as someone who has some personal knowledge of these issues, what my concern is that, and rightly so, we're supporting people and families who've got very impacted ability to look after themselves and all that sort of stuff. But equally, what's our approach going to be for dealing and supporting people who actually can achieve a great deal, but actually still need that support to stay safe, etc., and also ensure that they have a healthy life? Because actually, there's actually a lot of disabilities that impact on people and their, for example, choice of foods that they eat, or choice of other lifestyles that they may, risky lifestyles that they might want to go down. And I think my concern, having been through this, I say not me personally, but I have some knowledge of this, is that currently what we do isn't terribly robust. There isn't a lot there for people to, particularly higher able, those who are more able, got higher capacity to do things. It's the more capacity and more ability you have, the less there is appears to be able for people to be supported. So I'm just wondering how that's good, but it doesn't mean the impact is any less on that person. So I'm just wondering how that's going to be addressed. Thank you.
Good.
Thank you, Chair.
So
I think,
yeah.
Sorry.
Go on. Do you want to go first?
Sorry. Am I all right to go first, or do you want to go first, Mike? Okay, so I think for me there's something there around we can strengthen the work around the inequalities, because we know that there are particular groups that you mentioned in terms of special educational needs and learning disabilities around how we can strengthen that through the strategy. But I think there is something around working with our colleagues in children's and adults around the work that they're already doing around this agenda, and we can strengthen that certainly in the strategy, but also linking into some of the LLR groups. So I know there's an LLR group around learning disabilities, for instance, that did quite a lot around COVID vaccinations and access to those, for example. So I think what I would say is, if it's something that we feel that we need to strengthen in the strategy, then we can certainly look at that, and we can certainly put in the lens around working with those individuals that are more able, and talking around the risk-taking behaviour. We can link that into the sort of staying safe agenda around that. But Mike, did you want to come in on that? Sorry, did I?
No, it's fine. I guess I was just trying to work out what would be in the context of the strategy, and whether actually the point is, I think it would be a worthwhile conversation, possibly through the joint DMT with children and adults colleagues, just around how do we bring our public health services to bear on that group of people, and not necessarily in a kind of tight definition, but you'd want to take our overarching services, the lifestyle ones, if you like, and make certain they're not just universal, they are doing something for specific groups. I don't think that necessarily, I mean, it needs to be part of the health and wellbeing strategy, but I just kind of feel that's almost a kind of, we should just get on and do that anyway piece of work.
If I can just come back, what I'm really getting at, I think for young children, I mean, children who've just been born, children in school, I think, we've got very good processes, and the strategy is very clear. I think once young people leave formal education, 17, 18, it becomes then a bit kind of more, you're on your Todd, on your own. And I think that's where it becomes less clear currently what our there is stuff there, but it's less clear. So I'm just wondering how this strategy is going to address. I mean, it's a delivery thing, but the strategy is then very silent on these, I suppose, 18 to 25. And given we've got a responsibility up to the age of 25, strategy is quite silent on that. It's lots of stuff about young people, youngsters, which is fine, but what's the strategy for older? Thank you.
Steve, I'd suggest there's probably one to take away that there's something about transitions, because you're getting into that transitions bit as well, which if it's not coming out probably does need to. So
yeah, I mean, if I can just add to that, we have actually got in the sort of preparing for life section on the children's bit, we have got a specific commitment around ensuring children with learning disabilities have a seamless transition into adulthood. But maybe we just need to think around how we word that a little bit more, make that a little bit broader in terms of making sure it's a safe and supportive transition, and try and pick up some of those risk-taking behaviours and things like that. Because I know there will be work being done around how we can support particular groups to access prevention services, but maybe we can just expand on that a little bit more.
Okay, thank you very much. Mrs. Richardson, you wanted to come in.
Thank you. I think it's worth just reminding you, this strategy is a very high-level strategy. There's a development plan that will be going on alongside this, which will be linking into all the various areas. I mean, we have a lot of health issues, as you've already pointed out, in children and families. We have it in adults and communities. So we've got to pull all these areas in, as well as for other partners. And that's the work that will be going on behind this strategy. So I think it's just worth highlighting that.
Okay, good point. Thank you very much. Mr. Hack, you've got the next set of questions.
Thank you, Chair. Just a couple of things just on the document itself. Figure 2 is really difficult to read. Even when I've looked at it and tried to pixelate it out, it's just really tricky to read. Figure 3, one of the things that I thought would be interesting, and I don't know whether or not we can add to this, is healthy life expectancies, because we talk a lot about comorbidity and people who with long-term issues all the way through the document. I don't know whether or not actually to bring that forward in this figure might be quite useful, because clearly that's where we are worried actually on healthy life expectancy, and that's something that I know Mike has actually brought to this committee before. On the it's difficult because we've got 2 pages. On page 14 of the report, that page 35 in your pack, at the top, it says the high uptake of COVID vaccination in 12 to 17-year-olds. I didn't know if this might be in the wrong place and whether or not it might be better served in the COVID section of the document, because I just feel it probably more neatly to pop that all together. I suppose overall, my overwhelming thing when I read the document is just how frustrating and how difficult it was to read, looking at some of the issues that Leicestershire, the health of Leicestershire population is facing. We're performing significantly worse, not getting any better, and I think that is just demonstrates the how much work needs to be done in this strategy period. And if there was ever a document that would actually be something I'd present to government in terms of getting fair funding, with this one, because clearly we've seen how Leicestershire is starting to really get impacted by not just finances of our population, but the finances of the county as well. Just really quickly on a specific point is, I know this is a high level document, but there's quite a lot of stuff in here that's sort of left to guesswork, and I didn't know whether or not we could put a little bit more detail. For example, on page 40 or page 19 in the pack, it says, what does success look like? Reduction of rates of falls across Leicestershire for people aged 65 being on a par with the best performing authorities. Well, if we know what that is, it'd be great to see what movement are we expecting to see. Now, I know that will be in the development plan, but actually in the strategy, it'd be useful to see some specific examples, because there's lots of that where we actually are saying we'd like to strategize about this, but we don't really know what it looks like. We don't know, and we don't know where we want to go. And I would really like to see that in our strategies. What do we want to see at the end of this document? And at the moment, I think that could be brought forward a little bit more clearly. Thank you.
Okay, thank you very much. Mike, do you want to take this one?
Yeah, thank you, Chair. So I think that the introductory comments are just ones I'd agree with. Totally get the point about healthy life expectancy. I think I'd also say I'm worried about life expectancy generally, because those increases had stalled and are going backwards, and will do with the effect of COVID as well. Fairer funding, yeah, I mean, yes, I would support that. Obviously, we're coming on to the MTFS paper, and never mind fairer funding, I don't even know what the extent of the public health grant is for next year, let alone a longer term settlement. All of those we can take forward. Viv, I don't know if you want to pick up a bit about the, dare I call them success measures, but actually detailing what good looks like.
Yeah, thanks, Mike. I mean, yeah, we can certainly look at adding more detail in. I think one of the things that we were just a bit unsure about doing that in terms of putting specifics was obviously because the data can change so quickly, and we wanted to keep it as live a document as possible. But one of the things that we will be doing is we're going to be developing a dashboard similar to what you get for Scrutiny, actually, that will go to the Health and Wellbeing Board on a regular basis, which we will very clearly have our baseline in. So it's just whether we need to put that into the strategy as well, or whether you're happy that we can put that in the dashboard approach that we're moving that forward, and acknowledging for some areas, for some indicators, we'll have very clear progress and know where we are now, but for some other areas we've got to look at how we collect that data. So it's just being aware that some will be more developed than others, I suppose, on some of those success measures.
Okay, thank you very much for that. That would be helpful. And I think actually Amanda's comments about some of the visibility of some of the graphics, I think if obviously the final version is sort of cleaned up a bit and we can actually see some of those, because some of them are actually very densely informative, but hard to read. Okay, look, we haven't got any further comments. You've got 10 seconds, Mr. King. 10 seconds.
Okay, thanks for that. So just picking up from what Mrs. Hack was just talking about, and just looking at this, I think one of the things is that in some of the what does success look like measures, I think there's perhaps some thoughts need to be given about consistency. There is some inconsistency. Some of them are also very precise, and yet some of them are incredibly vague and open. So I'm wondering, I mean, it's this huge but just going back to the point I was making earlier about disability, we've got no specific commitments, for example, to increasing employment of disabled young, people up to the age of 25 in the workplace. I can't see it anywhere. And that, given that they have the lowest rates of unemployment, the highest rates of unemployment of any subgroup of population, surely that's our ambition, isn't it?
I'm assuming that comes under a different heading on the basis that it's
through it.
But on the basis it's not directly linked to health.
I think you're right. I'm fairly certain. I'm looking at colleagues. I would imagine it would go to the adult scrutiny committee because it would be a key indicator there, but it does need to be reflected in this as well. Not at least for awareness, if not for scrutiny. Wary of mixing and matching the purposes of scrutiny committees.
Absolutely. Okay. Thank you.
Just a thought, Chair. I don't know if Andy and Kate are listening in. I know we're somewhere away from the performance dashboard, but just listening to the comments around the performance dashboard, there's a bit of me on stage probably worthwhile reviewing what comes to this scrutiny committee in terms of the dashboard. Some of the performance dashboard we've got at the moment is the kind of NHS targets that we need to be aware of, but there is something for me, which is, I think, your point, Viv. At what point is it more useful to have a dashboard which is reflective of the health and wellbeing strategy indicators as a whole, and make certain that comes to committee on a regular basis, instead of it being a kind of yearly update on the strategy and then a dashboard that bears no resemblance to it the rest of the year?
I think that would be welcome, to be honest. Particularly where it's relevant to something that we've actually generated ourselves, our own strategy. So I think that would be welcome. Thank you. Okay, I can see nods, so that's good. Look, thank you very much. It's really ambitious strategy, so but obviously quite broad at the moment. The delivery plans that come behind it, I think, will be fascinating to see how they sort of flesh out some of the targets, how performance related they are. But certainly the sort of updated dashboard, I think, would be a useful outcome. So that would be welcome. Look, thank you very much, Viv. Thank you for answering any questions. So we now move on to item 9, which is the medium-term financial strategy. This covers the period, 3-year period, obviously from 2022-23 up to 2026. We have Louise Richardson with us, who's our Cabinet Lead Member for Health. And obviously Mike is already here, who's our Director of Public Health. We also have Sam Barrett, who's our Finance Analyst, who hopefully will pop up onto the screen at some point soon. Are you there, Sam?
Good afternoon, Chair.
There we go, you're there. Fantastic, you can hear us. Thank you very much. So again, we have the usual sort of structure for looking at the MTFS, which is splitting into sort of 4 chunks, and we will take probably sort of 10 minutes on each to go through where we are. So again, any specific questions on the elements which are covered, we're going to start off with paragraphs 5 to 16, which is the service transformation, proposed revenue, budget, and budget changes and adjustments. And again, on each of these, I don't know whether, Sam, you actually want to give us literally sort of 20 or 30 second snapshot of each of these areas, and then we'll lead on to any questions or any discussions. Or actually, Mike possibly will. I don't know. Mike probably will instead. He's volunteering instead. And then we'll go through the paper that way in a structured way, and then hopefully conclude at the end of it. So I'll pass over to Mike at this moment. Oh, actually, Louise, do you want to say something to start off with?
Thank you. I just wanted to say, obviously, we have as much of a difficult time with budget as anywhere else in the County Council. We still don't know our grant allocation for next year from Public Health, and we rely on a number of other funds coming in to support the work we do. You'll see in the budget that there's a number of projects that have gone to we're working with Transformation Board to try and get the best value and the best provision we can. We have got savings to make as well, but I'm aware that prevention gives us savings in a lot of other areas, and so we have got to be aware that we can't cut to the core and lose the services that we really need. So with that, I'll pass you on to the people who know the budget far better.
As if I was one of them. There we go. Thank you, Chair, and thank you, Mrs. Richardson. So, as well as Sam, I'm just going to pull in Adrian Allen, who's on the call, as well as the department's head of design and delivery, for comment as well as we go through the paper. In terms of paragraphs 5 to 16, I think the key points are, as Mrs. Richardson has said, we don't know the grant for next year, so it feels slightly uncomfortable being able to detail a paper that tells you where we'll spend the money and how we'll save the money. Doesn't actually tell you how much money there'll be, but we will assume that the Chancellor will stick with his statement that there'll be a real terms increase on last year's budget, which is approximately £25.5 million. For the purposes of the paper, we've taken the settlement as if it was flat cash rather than a real terms increase. So that's where we are with that one. Obviously, we've received significant money within the department this year, £3 million through the COVID funds to help us both tackle COVID and then also some of the recovery from COVID as well, which has given us a bit of flexibility around the budget in terms of our services. The way we structure our services, and where there's members new to Scrutiny, several years ago we did do an early help and prevention review within the authority. It was about 2015 and 16. The upshot being, from my point of view, I would, as a department, we would always support those services which try and nip things in the bud. So we'd always say prevention is better than cure. If we can intervene at the earliest possible stage of prevention and the cheapest bit of prevention, it then saves demand on our more expensive preventative, sort of more treatment preventative services like sexual health. To that extent, we've then got a mix of a lot of our budget, as you'll see in paragraph 12, is tied up with externally commissioned contracts from the NHS for things like health visiting, school nursing, substance misuse treatment service and sexual health treatment services. The rest of our budget is tied up in mainly our kind of internal delivery, so working around smoking cessation, physical activity, support to the community through local area coordination, support and advice through First Contact Plus being just a few examples. So we do structure our services in line with the early help and prevention review from a few years ago. In terms of paragraph 8, this is the one I can never get right and where I'll call on Sam. So Sam, I always need your help to describe what that original prior year budget minus £1.5 million in the next few years actually means. Is that our savings target overall?
That's a cumulative savings target over the period in which savings targets have been applied to the public health budget. So at some point in the past, there will have been a balanced budget where your spending was equal to the grant that you were given. However, what we have levied against public health are savings targets year on year that then frees up that public health grant to allow spend elsewhere within the organisation, within other departments, on preventative measures as well.
Thanks, Sam. And I guess that's important bit is, given the nature of the grant, we can't just save the money. We need to make certain that it's then substituted and allowed to be spent on other preventative services within the grant conditions within the authority, which is quite a long list now as we go along. Last point, I think for me on this one, there's obviously a few bits there around sort of pension contributions, etc., etc. Talked about this in paragraph 12. So having talked about the amount of money which goes on externally commissioned services, you can see, I think it worked out, 72% of our entire budget goes on the three areas of children's public health, 0 to 19, sexual health and substance misuse. So the NHS provide the health visiting and school nursing services, and the sexual health service, we have a third sector provider, Turning Point, that provides substance misuse treatment services. So actually the vast majority of my budget is tied up in three treatment commissioned, externally commissioned parts. The rest of it, I think, hopefully we provide very good value for money in trying to tackle everything else that makes a difference to people's health, which isn't just about lifestyle behaviour services, but where we talk about things like public health leadership and public health advice. That's the core cost, if you like, of my department in advising other partners, the NHS, district council colleagues, other parts of the county council on things, as Viv was saying, around health equity audits, health and all policies, and helping drive that policy and strategy agenda. So there's an awful lot in there, which I think we do with the money, but that's essentially where it is at the moment and what we currently spend it on. And I'll pause there before we come to savings.
Okay, thank you very much. Do we have any questions on this one? I have to say the way the budget is presented probably must be an absolute nightmare for internally to actually try and rationalise it. But it is an extraordinarily odd way of presenting budget information. I've got my head around it, but not particularly easy to try and work out minus percentages. So are there any questions on this particular bit? And this is just the bit. So it's basically Table 2, I think, and also Table 1 are probably the key items that are within the section. So we have no questions on that. Okay, look, thank you very much. Okay, we're going to move on to the second section now, which is labelled growth, which are basically pages 56 to 63. Back to you, Mike.
Yeah, I've got growth as just being paragraph 17, so it could be a very short bit. The answer being there is no growth that's submitted by public health. I think it's worthwhile saying that's not to say that there aren't cost pressures within public health. Some of that will be demand led because a number of our services, we can't cap activity, so sexual health needs to be open to everybody. We can't just close the doors on it. I think from a commissioning point of view and the contracting point of view, which Adrian leads on, I think it's worthwhile knowing that where there's been cost pressures, wage increases in the NHS would be a classic example. We contract with them so that they basically consume their own smoke in terms of sucking up the wage increase. So although we've not put a growth bid in to the centre, to the corporate departments around growth in the public health budget, that's not to say there isn't a deal of cost pressure which we manage internally. I don't know if you'll add to that, Adrian, is that about right?
Yeah, that's right, Mike. There was a small amount of increase in terms of NHS salary costs as part of the Agenda for Change deal that happened about 3 years ago, and we had some responsibility for contributing to that, but we also had an increase in the grant funding that came down to us. So that cost pressure wasn't realised by us as a department and obviously as the council. As Mike said, we do everything we can to try and work with providers to redesign during the course of larger contracts, especially within our large services where we commission with multiple £1 million, to be able to take advantage of redeveloping staffing structures. When people retire, we support them with working in a more digital way. So we always try and get them to be able to swallow the increase in on costs rather than coming to us for additional money. So it just gives us this position at the end of the year where we're not putting additional pressure on the wider council budget.
Okay, thank you very much for that. And apologies on the confusion. It turned out actually it's Appendix B on page 63, which also, strange enough, under growth says 0. So your analysis was correct, Mike, which is paragraph 17 and Appendix B both say the same thing.
Right, thank you. So I'll go on to savings then. And Adrian, this is where I suggest we do a bit of a double act.
Whoa, you can't get away. 0 doesn't necessarily mean you get no questions. Okay, I think we've got Councillor King. Any other questions on this bit before we move on? Okay, just Councillor King. Councillor King, you've got 0 as your question.
Well, 0, yeah. Yeah, thanks for that. Look, being a relatively new county councillor, I do understand the financial pressures that county council is under, however, but equally, having read now the savings, which talks about how reductions have been made since 2016 to the prevention budget, and I'm just wondering, and also, you know, obviously we've got the situation with the pandemic. We're obviously going to have increased pressures on some of the activities that public health undertake, and yet we've got no allowance currently in the MTFS for any increased demand on some of those services. And one of the demands, in addition to that, is population growth. And you just mentioned, Mike, about there's a contract for children's and schools health. If we've got increasing population of young people in school and children, then clearly there's going to be an increased demand for that service. I assume the population isn't standing still for the next 3 years. So how is that feasible to do that? If you haven't got an increased budget, is the NHS going to be putting more money into that budget? It's hard to fathom this out from this report. But equally, going back to the COVID situation, are we going to need, and therefore is it a false economy to, you know, we're talking about prevention earlier, about having a health and wellbeing strategy that's going to, is it a false economy to be demonstrating there's going to be no need for any growth? because I'm not quite sure that is the right answer. Thank you.
Yeah, thank you, Mr. King. I think it's difficult not to agree with your comments. Would any director say, is their budget big enough? I don't think any director would go, oh no, that's fine actually. I'm not going to be any different for anyone else by saying exactly the same. Yes, the budget, it's come down by 25% in real terms since 2015-16. So we've been managing a decreasing budget. We've got no certainty about what the public health grant's going to be next year at all. And in the context of the council finances and everything else you said, demographic change, return from COVID and everything else, that puts a significant strain on all our services. We have, I'm always proud of what the department's done over the years in terms of the recommissioning work with those external providers to screw every single last penny and every nut and bolt down to try and be as efficient as we can do. Equally proud of where we've done our own redesign work and brought it in-house, transferring smoke cessation and weight management to a digital model to give us more efficient ways of doing it. I think we've had an exemplary record over the last 8 years since we transferred to try to get extra value from the services we've got. Do we eventually reach a stage, and again, we're not alone in the council in that, of running out of ideas about how to save money or suck up growth? Would be a fair challenge. And I don't know, in all honesty, if I can answer that one in the way that I'd want to.
Mark, can I come in? Yeah.
Oh, no.
Well, just I think there's a few things just in terms of answering the question directly. Specifically around growth in population, and this is what we alluded to earlier. What we are doing is taking every single opportunity that we have in terms of our commissioning cycle to be able to work with providers and new providers to be able to swallow up that pressure. So one of the things that we've done specifically with our 0 to 19 service, which is being split and recommissioned over the next 12 months, is that we've been really clear and honest in our procurement processes by saying we're not putting a cost saving against this service because we've taken money out of that service previously. But what we are doing as part of that commissioning piece is redesigning the service. As I said, we're splitting that up, but we're also working with the new providers moving forward to be able to be really clear with the modelling by saying, the population is increasing at this level, and the providers or the potential providers that are bidding for that work are having to take that into account. So although we're not putting a cost saving against the service, we're also dealing with no extended cost pressures. So that's how we're trying to balance our commissioning work out. So we're not having to take big chunks of money out of our commission services moving forward. As Mike said, we've done that over the last 6 to 7 years. And this is the point we're at now. If we take any more out, they won't be sustainable or viable. But what we are doing is forcing through the procurement route providers who bid for the work to be able to model in that growth moving forward. And just in terms of the other question around the COVID money, what isn't explicitly reported in here is that public health did have or has had additional money for the COVID response. I think paragraph 5 or 6 talks about the £3 million that we had during this year for the COVID response. It's that additional money specifically for responding to COVID that we're using to deal with any pressures that are coming directly out of the back of the COVID pandemic, again, rather than asking the central pot for additional money.
Okay, thank you very much for that. Amanda, you've got a question.
Yeah, it's just, I think this is, I like these reports where they all sort of connect to one another. We've obviously just gone through the strategy for the next 10 years, and that strategy has set us some really challenging objectives. And at the moment, I don't know how we're going to get there if we've got no growth in the budget. And it makes it very difficult because actually what we're finding is with the current spend capacity we've got, things are not getting any better. Actually, some areas have regressed. So how do we transform this budget into something that is going to deliver the strategy? And sorry, that's outside my pay grade, but my concern is that we have a MTFS document in front of us and we have a really ambitious requirement in the paper before, and at the moment they don't really connect to one another quite as much as maybe they could.
Okay, Mike is going to give you a very good answer on that.
No, I know it's a fair challenge, and as I say, I wouldn't disagree that we need more money. I guess the only mitigation for me is from a strategy point of view, there's only so much of the strategy is about service delivery. So it's not to say that I'm not going to argue that services are really important, but actually it's a shame Viv's dropped off the call, but some of that stuff that is about how do we utilise all, it's all the policy making stuff and all the strategy making stuff. How do we get into the infrastructure developments? How do we make our developments healthier by design? That's the bit, if you like, in some ways is the panacea. What can we do that builds in good health at the start instead of then relying on services to make people healthier, which isn't a full answer, but I suppose I wouldn't want the strategy just to be seen about the services that we or other partners deliver.
Louise.
Thank you. I think Public Health has shown that they have a really good handle on managing the budgets over the, they've had a lot of savings to make. They've also had to be, they've got a very wide, broad spectrum of provision they have to offer. And I know Adrian is, there's a lot of work done through recommissioning and and having those hard discussions. But I think going forward, and especially with the joint health and wellbeing strategy, with the ICS coming on board, there is far more connection now between all the various partners, NHS, LPTs, CCGs, whatever, and the council. And I think there's got to be more movement in sharing the load, to be perfectly honest. And what we can do in prevention can save the NHS money, and it's about those different dialogues to happen.
Absolutely. Thank you very much. Okay, look, I think, should we move on to savings? Because I think we're probably, to be frank, we've probably sort of bled into savings and savings under development as well. So, Mike, do you want to move on to the next bit, and then we can ask some questions about that?
Yeah, thanks, Chair. We'll do. Again, Adrian suggests we do a bit of a double act on this one. I mean, I think I'd recognise that we've, because of the reasons Adrian set out, really, that have tried to backload our savings in the current NTFS, recognising the pressures we're under, and also giving us time to think about how can we do things differently, given that we've taken large amounts of money out in the previous years. To go through each individual one, PH1 is fairly easy. So I talked about the early help and prevention review in 2015-2016. There was about £1 million worth of savings identified in that review, which basically said, if we brought preventative services across the council under one banner, under public health, what would be the opportunities to be more efficient? That's been an ongoing programme. So the remaining 65 is essentially kind of the full year effect of things that we implemented in previous years. I don't think it's a new cut as such, is it, Adrian? Right. Then in terms of the next ones, again, PH2 and PH3 are an opportunity for us to look at both our internally delivered services and the externally commissioned ones. Internally, again, Adrian, I don't know if you want to say anything extra. From my point of view, I'd recognise, I think, bringing the smoking cessation service in-house and digitising it largely has been a really good success. We've now done that with weight management. The next stage in integration is almost, if you like, take these two services which currently sit underneath, they're underneath an umbrella, if you like, but actually look at what we can do to bring them together to provide an integrated lifestyle service. Would that then open up opportunity to save that amount of money by 24-25? I don't know if you want to come in on that point.
Yeah, I think there's a few other services that we have internally as well that we're looking to put into the integrated lifestyle service. So potentially quite large budgets that we're hoping to bring together. So we're confident of the saving, but that saving is generally around redesigning internally and taking out any potential crossovers or duplication that we have within those services when they come together.
Cheers, thank you. The externally commissioned services, again, when things come up for recommissioning and recontracting, we always look to see what we can do to make them more efficient. No detail on this one. My working assumption is with some of this is for things like sexual health, we have learned some lessons through the COVID pandemic about how people respond to offering things that were previously face-to-face digitally. Some of the sexual health service provision has certainly been a good indicator of that. That should in turn generate something which we can then put into the service specification and will allow us to take money out of those particular areas. Again, Adrian, don't know if you wish to add to that one.
not really the 35,000 that we've pulled in for 22-23 was an early saving that we were able to make. That was a new opportunity, so we've took the opportunity to do that. The rest of it is being scoped, but again, we're fairly confident that within that time frame, there's a number of opportunities that we can look at to bring the rest of the money out.
Cheers, thank you. Paragraph 23, weight management and indeed exercise on prescription. We have paid other organisations to coordinate that programme for us in the past, related, I think, to the internal review of the lifestyle change services. I think there's an opportunity there to bring that in-house as part of that umbrella. So we'll be looking to save some money in just basically our administration costs, if you like, of various programmes. Health checks is early days. Of course, health checks is a statutory requirement that we deliver a programme of health checks to the 40 to 74-year-old population. That's currently delivered by GPs. I think with that one, we're currently going through an options appraisal, which would look at what is the best way of doing that. A variety of things in there. I'm sure GPs wouldn't want to lose the income, but we do need a conversation with GP partners along the lines of what is the best use of their time, given the pressure that primary care is under. If there was then ability to look at a mixed model of primary care and internal delivery, or having our own in-house health checks team which delivered that service, they would be the kind of options which I think should reduce the core budget of health checks. But I heard a side. Do you want to come in? Adrian, do you want to comment on that as well?
Sorry, yeah, no, sorry, I didn't know you were looking at me. I was just going to say, I think one of the things that one of the reasons why we're looking at this again is that over the past 3 or 4 years where we've commissioned this service, we're acutely aware that there are some really hard to reach groups within the community across the whole of the county that are not engaging with the health check programme. And as Mike said, it's a statutory duty, and therefore, you know, we really need to look at what we need to put in on the top of the GP service that we currently have now. But we think by digitalising some of this and actually, I suppose, targeting a little bit more those hard to reach groups, we should be able to make a saving on that. We just don't know exactly how much or when that's going to be yet, because we're still quite at early stages with those conversations. We're very busy at looking at what other authorities have done, and COVID has given us an opportunity to really start to think about pushing the boundaries in terms of health check delivery. So there's lots of information coming in that we need to digest before we embark on the redesign piece.
Thank you. And then lastly, the last three, prescribing recharge is almost a historical anomaly. I think we do pay the CCGs on a recharge basis for their prescription costs for things related to public health activities, so prescribing charges for smoker cessation, nicotine, etc., etc. There's no right or wrong answer in this one, but we have realised that other authorities don't get charged in the same way, so we will enter into a negotiation with CCGs to see if they would be interested in at least a risk share model to share those prescribing charges. Commercialisation, we've been talking about this for some time. We've always provided a free Healthy Schools offer to schools, because I do think Healthy Schools programme is really important. Other authorities do provide that on a charged for basis, and again, given the state of our finances, I do think that's something we need to consider, and colleagues are working on that. And then to go back to paragraph 26, service efficiency, I suppose, is a catch-all, which is we would always review our budgets on a ongoing basis just to see what extra efficiencies we might throw up. So again, Adrian, I'll just touch you if there's anything you want to add to those.
Yeah, I think the service efficiencies one is a really important one, and as Mike said, we are always constantly reviewing our interactions with service users. But I suppose just to put a bit of detail around that one, this is not around withdrawing services from users. This is just about interacting in more efficient ways. Some of this is around how we prescribe with service users. So, for instance, from our Start Smoking service, we use a combination of prescription therapies, pharmacotherapy, to be able to support residents on their Start Smoking journey, and through our own experiences, but also through research and academic papers that come out, things around electronic cigarettes and different combinations of gums and patches and things. We're always reviewing the interactions that we have with individuals and communities and the different combinations of therapies. Using an electronic cigarette with a gum sometimes is cheaper than using patches and gum together. So it's all of these things that we put all together. So we are always constantly doing this, but actually we've got a lot more data now on the use of things like electronic cigarettes, things like the voucher schemes that we use in weight management, and some of our other interactions. So we're just embarking now on a review of that. So increasing interactions with service users, but reducing the cost of that interaction is what we're effectively doing. And the commercialisation piece, just quickly, as Mike said, we're really looking at this as a broader project than we originally started. Originally started with just the schools offer, but as the paper says, we're looking at our offer to workplaces now. We have a really robust offer of training and development already in the department that's always been funded by the grant, but actually we're moving that, or we're proposing to move that into a commercial offer across schools and workplaces. So there's a huge amount of work with the transformation unit happening around that, and with Sam as well, about how we model that moving forward.
Thanks, Adrian. So in summary, Chair, I mean, basically a combination of kind of service redesign and efficiency, as opposed to straightforward lobbing off bits of the service delivery piece, or where we need to put more detail on them, but hopefully that gives a flavour of what we'd be looking to do in terms of those areas.
No, thanks a lot for that. Very clear. Are there any questions that anyone has? I think that was an extraordinarily clear summary. So thank you very much, Adrian. Thank you very much, Mike. No questions. Okay, that's good. Thank you very much. Do you want to move on to the final section in that case, Mike?
Yes, thank you. I think we've kind of covered this. So just in terms of external influences, we've mentioned that a number of our services are demand-led, so therefore there is always an element of uncertainty about what the outturn will be, because it depends on what comes through the door. Inflation and how we work with providers for them to meet the costs of wage inflation we've covered. And lastly, we've talked about the uncertainty in the public health grant in the immediate years. So there's nothing much to say on 28, 29 and 30. And then other funding sources, I suppose it'd be fair to recognise we've probably got more external funding sources than we've ever had before, not just the COVID grant, but as you can see, we do receive allocations from other bodies as their contribution to some of our services, be it First Contact Plus or from the OPCC, etc. And as always, I should point out the £297,000 from Rutland isn't just the amount of money they pay me. It is actually for the public health service. It'd be nice if it was.
Thank you for that clarification. We're obviously, somebody has obviously asked you that question before. Again, pretty clear summary. The figures are what they are. Can I ask one question? When are you actually expecting confirmation of the budget?
I have no idea. So it's probably about the latest I can remember. Sometimes it's come out just before Christmas. To get to the third week of January and still not know is a concern. So I don't know.
Okay, thank you very much. Yeah, I can understand why that's a concern. Okay, I can't see any questions on that section either. So thank you very much to the three of you for summarising the MTFS. I think we've pretty well covered it as an item. We've plenty of questions earlier on, but I think the final two sections in particular are extraordinarily clear. Sorry, Mr. King, go for it.
Yeah, no, I haven't raised a specific question in those sections, but I think I retain, whilst I understand we can do service redesigns and we can obviously, none of us are against efficiencies where it doesn't impact on I don't mean delivery in that sense, but in terms of outcomes. It's about improving the health and well-being. We've just had, as Mrs. Hack mentioned earlier, we've got a very ambitious health and well-being strategy that outlines what we want to try and do. And we've got some areas where we've got some issues where we've been going downhill in terms of some of the health and well-being before the pandemic. And what I'm concerned about is how we're going to address, how's this strategy, how are we going to make sure we've got enough resources to address how we're going to deliver that strategy in all its shape, ways and forms, so that when we next look at, when we look at this in the future, we're not saying, oh, we still haven't managed to achieve this, that, the other. Health and well-being of people in certain segments is still not as good as it could be. So then the question then is that because we haven't put enough resources into it? Because you can only redesign and redo some of these services so many times before it's not having the desired outcome. So I'm wondering, where are we in that point? If you could explain, Mike, please.
Yeah, I think my view on that one would be, obviously this is about our budget and the service we deliver for that budget. I think the point, and I know we had a conversation about this before this meeting, there is something, and Adrian, good, you're on the line. There is something for me about quantifying, well, what is it we get from the money that we then spend on this? So from my point of view, I'd say as a department, we monitor our outcomes, we monitor our outputs, I should say. And if it's useful to come to Scrutiny with our emerging public health strategy and say, actually, £611,000 on smoking cessation equates to this number of quitters and these number of people that then quit 12 months, etc., etc. That's the stuff we do internally, but would help, I think, flesh out what's the outcome of this particular part of the piece. The other bit for me is, as a strategy, of course, is not just about me, it's about the rest of the county council, district and boroughs, NHS partners. And you then get into that debate, which, to be fair, we haven't had for a number of years, which we used to do back in the days of, I forget his name. There was the guy who came up with 3 different scenarios, the fully engaged scenario, and it was going to be about the cost to the NHS if we didn't engage people with around their health. He was the finance and audit chair at Northern Rock, which is why it's somewhat discredited, I would say. But the point for me is actually there is a separate piece of work through the Health and Wellbeing Board, which is probably looking at that going, what's the collective sum of resources we are bringing to bear on prevention? And do we think it's enough to then meet the outcomes of the strategy? So there's almost 2 separate bits. There's the value for money from my budget, the budget, and then there's the piece more broadly around the strategy, and are we spending enough on prevention globally? They are joined, but I think they're 2 very separate questions.
Thank you very much for that. Okay, I think it was referenced earlier on by Amanda that this agenda has sort of brought together, I think, 3 very sort of tie together items. Obviously, we started with the strategy, then talked about the finances, and now we're on to the outcomes, the performance. So item 10 is our health performance update. As usual, this report is going to be presented by Andy Brown from the Chief Executive's Department, also Kate Allardyce, who's from the Commissioning Support Unit, and they have other officers online who hopefully can introduce themselves as and when. So over to you, Andy and Kate, to give us a brief summary of sort of the key points, I think, from the performance report. I think it's probably fair to say that it's probably not the best outcome that we've ever seen at the Scrutiny Commission, but hopefully you can help summarise, and then we can move on to discussions and questions.
Yes, thank you very much, Chair. If I can kick off and then hand over to Hannah and Kate for the sort of the middle section around CCG and acute performance and some of the pressures in the ICS system. In terms of the report itself, it's based on data that we had available at the end of December, so sort of around the Christmas period. And clearly we have had some more data, particularly around COVID since then. So I'll say a little bit more about the latest data. It draws a lot on the statutory frameworks for health and care, looking at things like the FOF performance indicators, the ASCOF framework, and also the NHS oversight framework from 2019. Now, a lot of that is moving on. So moving forward, we will be bringing you a different type of report, a tighter report, focused largely on the health and wellbeing strategy that you've mentioned, but also other priorities within the ICS system. So we're working on that at the moment, and we're very open to the committee's views on what they'd like to see moving forward, and clearly we want to provide the committee with what it needs to hold this system to account. So we will be making some revisions moving forwards. So at the moment, the COVID-19 data, really put that there for the record and for context in terms of the later pressures that come through in the report. And a lot of this will be known to members, so I won't go through this in great detail, because clearly you've been having sort of regular data flows and briefings on this, and a lot in the national press. So the data that we had at week 51 at the end of December was clearly at the peak of the Omicron wave, with significantly concerning levels of cases and prevalence in the community. It was almost sort of doubling every 2 days, very high levels of prevalence, and clearly very significant concerns for the system, right through the autumn, really, with the Delta wave and the amount of cases and level of excess deaths, but clearly moving into December, January, very significant pressures within the system. And that's very much reflected in those 2 reports, Appendix 1 and Appendix 2. Perhaps slightly more positively since then, we have seen a slight reduction in a plateauing and a reduction in some of those cases since then. The system still remains at level 4, a very high level, and still a bit of concern about potential underreporting, about the impact of schools and universities returning. and also about the number of cases moving up towards the over 60s, which has seen an increase, and also some care home outbreaks have increased as well. But within all that, the intensive care unit figures have remained reasonably low and stable. So that's one of the positives within that. But also workforce absence has been particularly high in both the health and care system and the council system and other partner agencies through that particular period. And clearly that has fed as well into some of the system pressures and some of the lower levels of outcomes and performance that we've started to see in some of the data coming through. So I didn't want to say too much more in terms of the context, and happy to sort of take any questions on that, or hand over to Hannah and Kate perhaps to take through the next section.
Okay, I think Amanda's got one question on that bit before we move on.
I might have got the wrong section. So I suppose, I mean, we have spoken about this many times before. This is under the CCG performance. So is this the right?
I think that's probably the next section. Actually, I think it might be worth just
Sorry, John.
Okay, we're jumping the gun. We're focusing on the key areas. Right? Do you want to go move on in that case, and then we'll come to questions on those bits.
Thank you, Chair. So if I just cover some of the CCG performance elements, my name's Hannah Hutchinson. I'm the Assistant Director of Performance Improvement with the 3 Leicestershire CCGs, soon to become Integrated Care System. So what we've been able to do in the report that's come through today is take some of the indicators and the performance metrics which are publicly available from the 2 clinical commissioning groups that at the moment cover county. So we've got West Leicestershire and East Leicestershire and Rutland. So at the moment we aren't able to have the data at the place level, but hopefully going forwards as we work towards developing the dashboard about the health and wellbeing strategy, we can kind of bring that together in one place. But at the moment, this has got Rutland data included. So we have pulled out a number of the performance metrics that are included in the NHS System Oversight Framework 21-22. From a governance perspective and the CCG, these are actually being reported to the Integrated Care System Quality and Performance Improvement Assurance Committee, which is called QPAC for short. And even with the acronym, it's still a bit of a mouthful. So QPAC receives this high-level performance report on a monthly basis, and then on a quarterly basis, we go through some of these details in much more depth so we can actually review and have the conversation and the dialogue around them, as well as the plans from the transformation groups that we call design groups. So we did this very recently back in January, but we've reported here as the time of submission of the paper, the October 2021 data, which was that was publicly available. So just to pull out a few points in terms of the key indicators that we've got here. Cancer 62-day referral to treatment, the national target is above 85%, and both East Leicestershire and Rutland and West Leicestershire were significantly below that. We know that we are in a fairly challenged position at the moment around cancer and around a number of areas, as I'll come on to in a moment, but there is a cancer group that are specifically looking at this and specifically looking at the information and the intelligence coming through to make sure that we've got action plans in place to try and improve performance. So one of the ways we're doing that is looking at the utilisation of the independent sector, where we can try and do diagnostics in areas other than acute trusts and hospitals. So utilisation of organisations such as the Alliance or the development of the Community Diagnostic Hub, and where we can really try and build on what's worked well remotely and kind of keep that going as well. So we do know that cancer obviously is an area that needs improvement, and there is a table in paragraph 18 that's got more cancer details within it. It's worth saying, because one of the questions that always comes up is from a county perspective, how many people are actually using University Hospitals of Leicester? And in November 2021, it was worth saying that 86% of patients were being referred there for their 2-week wait referral, and 84% of all patients for their 62-day treatment. So just to kind of give you a bit of context context, they are still very much the primary provider for most of the patients within the whole of LLR, including county. We've got some urgent care information here as well around A&E admission and the 4-hour target. That target has actually now kind of disappeared in some ways from the public domain, but it's a really good indicator and one that we're still very much familiar with in terms of how long are people and our residents waiting when they're actually going to seek acute and emergency care. So the numbers within the report, which I won't go through individually in the table, talk through the UHL A&E data and also the LLR urgent care centres, where you can see that 91% of all patients were seen within the 4-hour wait compared to 54% at UHL. Again, we're not alone in this position, so it's worth saying that North West Anglia NHS Foundation Trust were at 60% in the same time period, and University Hospitals of Derby and Burton were at 64.6%. So this is a challenge to everybody at the moment. We've been doing huge amounts of work, though, within the CCG around this, and not just health focused either, but through the flow board, which very much looks at patients from their journey of before they even call 999 and utilisation of 111 and prevention and self-care, all the way through to discharge from the trust and where care can be found, including quite complex care packages of care as well. So at the moment, one of the things we're trying to do is maximise the use of an on-site urgent treatment centre. So where patients go along, they are directed to the most appropriate healthcare professional, which is not always the person sat within A&E. We've got a number of indicators here as well around referral to treatment, so 18 weeks, and as well the number of patients waiting over 52 weeks and 104 weeks. And this probably is one of our most significant areas of challenge at this point in time. So East and West Leicestershire patients, including Rutland, we've got over 8,000 waiting over 52 weeks at the moment. And in terms of 104-week waits, we had 724 at the end of October. There are absolutely plans in place, though, to reduce that throughout the year, and we are monitoring what that looks like in terms of what additional support we can put in place to get these patients seen as soon as possible. Priority 1 and priority 2 patients, so those who need immediate care and care within 28 days, they are absolutely being prioritised. So we've had weekend insourcing for multiple specialities that started back in November. So hopefully we'll start to see some of these figures improve. And that's covered areas such as maxillofacial, urology and paediatric surgery. And we're also, where possible, moving patients to local other acute trusts as well. Some good news we've got is actually around mental health. We've got a new mental health IACT provider in place, and we've actually seen real improvement in our figures here, which is a good news story, bearing in mind everything that we've heard earlier around the impact of mental health and COVID. And it was really good as well to see that that was included within the health and wellbeing plan as well, and how the two are starting to link and dovetail together. So we did actually achieve the metric for the percentage of people who complete treatment and are moving to recovery in the county, which is great, and it was very nearly achieved as well for people accessing the IAPT services. And it's been a little while actually since we've seen this sort of position come through, so it's worth saying certainly at this point in time there's a lot going on around mental health, what we can do face to face, what we can do from an online perspective as well, certainly to try and reach some of the young people. I'll just go on to dementia, and then I'll pick out a couple of more points, and then I will open it up to questions unless Kate would like to add anything. So in terms of dementia, we've seen a slightly deteriorating position against the national target. We've achieved 60.5% of people aged over 65 with a diagnosis of dementia recorded in primary care. And I think this reflects the impact that primary care have seen during the COVID pandemic and are continuing to see. And yet What we do know is that that number hasn't gone down as much as it could have done. So I know we're not quite there, but given the role of primary care in the vaccination programme and in trying to manage the increased number of patients that they've got at the moment, I think that position has been fairly stable, and hopefully we'll start to see an increase. One of the ways that we're trying to get real traction on this is that Dementia Board are now represented fully at the Mental Health Design Group. So that's our transformation group, and actually the Dementia Strategy is coming to that LLR system group meeting in February next month. So hopefully that will be a really good way to find out what their plans and priorities are and what it is that they're going to look at as areas of improvement. Just in terms of never events from a quality perspective, as UHL is the only acute provider within Leicester, Leicestershire and Rutland, they're the ones that we have reported here. So we've actually had 6 never events at UHL between April 21 to September 21. And the most recent was for wrong site surgery and retained foreign object. And again, each of these are being fully reviewed, and we're looking at the root causes around this and what the learning is. And there was a whole trust-wide event that took place back in October with colleagues from across the community and the CCG as well, to try and focus on how we can improve learning from never events. And they're linking up with local universities now to try and specifically look at what are some of the human factors as well as the learning from the data coming through. I think I've talked through some of the areas of improvement, including IAPT, but it's just worth saying as well that primary care have really started to see an increase in GP appointments and face-to-face appointments as well. So that's a really good news story. Certainly at the moment, that's not always what the media portrays nationally, but our numbers are very much demonstrating that we can see this improvement. And we sort of touched on, finally, paragraph 21 and future reporting earlier in terms of the options that we've got available to us. And I think from that, we agreed that we would try and work alongside the Health and Wellbeing Strategy dashboard to produce some of this performance intelligence and information. So if we're happy to work in that way, then that's something certainly that Kate and I can pick up in the future. So I'll pause there.
Thank you very much. Amanda, did you want to come back on the question that you had before?
Thank you, Chair. Obviously, the report today is quite somber reading, really, in terms of where we are. I don't think we expected we were going to see massive improvements, particularly understanding what their position is in the media and all sorts. My question really, though, is on the table, one of the metrics in there is percentage of patients receiving first definitive treatment following referral from an NHS screening service within 62 days, and that East Leicestershire's performance was 38% and West Leicestershire better at 65%, but there's a huge difference between those two numbers. Do we know what the reason is behind there? And I suppose for us at Health Scrutiny, what impact is that having on the health and well-being of those patients that's obviously wanting to progress their treatment as soon as possible? What impact is that having on those individual and their, to put it bluntly, their long-term life chances?
I mean, I can certainly pick up in terms of the data that's behind those percentages. So we do have much smaller numbers of patients that come through the screening programme. So that could be one explanation in terms of the difference between East Leicestershire, Rutland and West Leicestershire percentages. We provide to the ICS board, as Hannah's outlined, a lot more detail in terms of the numbers behind those percentages. So we can certainly pull those out and let you have those. I think it might be quite useful when we're doing future reporting that we include some of that actually. So I can pick that up and email you separately if that's okay.
Okay, thank you very much for that. Phil, you've got a question.
Yeah, thank you. Thank you, Hannah, for your comments. I'm not going to go over what Mrs. Hack has just mentioned, but I would think I would certainly share that concern. What I was trying to get a sense of is the kind of the elective treatment, the delays, the wait for people who are on the non-urgent treatment that's required. So after our last meeting on the 10th of November, I actually got invited to have a meeting with Paula Vaughan, who then did explain to me in quite a lot of detail about the LLR totality. Now that was, I think that was before Christmas. So I think at the time she told me it was around 105,000 people across the LLR. This is obviously just the East ELR and West Leicestershire, isn't it? At 70, just under 75,000 at the end of October. And I think what's concerning is, and I think what we need to, Chair, if we can, is to get some idea of, you know, what the plan is to kind of get this right down, because obviously there are hundreds, you know, 100,000 people plus across LLR who are now currently waiting for treatment, and many of them have been waiting for considerable periods of time. And as I understand, approximately half of those people are MSK categories. So therefore that is likely to mean they're in considerable discomfort, pain, and having problems with mobility and other issues, which has consequential impacts across the board, not just on healthcare, but on social services, on district councils as well, in terms of providing funds, you know, disability facilities, grants to adapt properties and all of that. So I think, you know, it is a concern. I'm not looking for you to go into this now, but I think at a future meeting, Chair, it'd be extremely helpful if we could have more information about the breakdown by specialities, and also about the wider picture, not just Leicestershire, but what the maybe it's an issue for the joint scrutiny meeting to look at, because I think it is going to be over the next X number of years. This is going to be the number one. I think one of our biggest priorities is how is the healthcare system locally, not just health, but working with county and other stakeholders, going to address the very significant number of people who are waiting for non-urgent treatment. Because the longer people wait, and the medical people on this call will know, the more complex and the more difficult that condition, you know, will deteriorate and all the rest. So then when you do get to treating it, what you're going to have to do is going to have to be bigger. It's going to take longer to recover, and therefore its impacts on the person is greater. But there's also bigger financial impacts because it costs more, takes, you know, you get more hospital occupancy time, etc., etc. So there's consequential impacts the whole way across, sideways, up and down, whatever you want to describe it as. So I really wanted to try and understand that, you know, whether we could do that. And finally, Chair, the only other thing I wanted to ask is, we talked a bit about, and Hannah was talking about the ICS, and again in this report on, you know, what the progress is. But I just assume, Chair, that this committee will be involved in scrutinising the ICS, or will it not? It'd just be helpful if we could. I know this isn't part of this report, but it'd just be useful to understand that going forward, if that is going to be part of our remit or not. Thank you.
I think that last point I'll get confirmation from Ewan. Actually, understanding is that as a successful organisation as CCG, then we'll have the same connections to it that we did with the CCG.
Yeah, that's my expectation.
Yeah, Mr. King, you can ask them plenty of questions as well. I mean, the point on recovery, I think, is clearly probably at the focal is the focus of probably all health organisations at the moment, whether it's locally or nationally, and the plans. I know we had the beginning of the plan at the last this last scrutiny session, but obviously subsequent to that we've had another variant through the system, and I suspect the health service has been put back again, hopefully not as far as previous variant waves have done, but still a significant impact on the capacity of hospitals and the health service to be able to actually deal with the backlog of cases that we know exist in the system. Is there anyone that I'm looking at those on the screen at the moment that have any points that maybe directly respond to some of the points that Councillor Mr. King raised?
I'm happy to respond to a couple. We can absolutely provide the breakdowns by speciality. So we've got them for 52-week waits, we've got them for 104-week waits, and we can share that with you. The top 5 are pretty much the same for both, actually. So it's ear, nose and throat, general surgery, urology and trauma and orthopedics. And that's the cohort that we're looking at. There are, like we've talked about, there are plans in place. One of the biggest that's going to have an impact is actually the introduction of a Vanguard. So we've got a mobile Vanguard theatre coming, which is already staffed. And other areas of the country have already had this put into place during 2021, and it's really seen an improvement in their performance. So because it comes and it's ready staffed, we're already looking at patients that we can start introducing, and UHL have got that opening at the end of this month and another one coming either end of February or beginning of March time. I would need to clarify that. But if it would be helpful to start thinking about what plans do we have to decrease these numbers and how can we do it, it might be more helpful to get perhaps a one-page summary or something like that from those transformation group leads who are closest to it and can talk through some of that plan and action for the whole of LLR, if that would be useful.
I think that would be very useful indeed, and we talked about it earlier actually, so I suspect that we maybe have something on our next session to maybe start to have a look at that. Okay, Mike, do you want to come back?
Yeah, thank you, Chair. Just to chip in, Hannah, and obviously as much the committee could want to look at the elective backlog and the cancel weights. But my eye was just drawn by the Never event. So if I've read this right, I've got 2 Never events in the whole of 1920, 7 Never events in the whole of 2021, and then 6 Never events in the first 6 months of last year. Again, unfair to ask you, but I suppose the quiz question in my mind is this just a series of shouldn't happen, but they did individual events from which there'll be individual learning? Or is it something more systematic around patient safety at a time of COVID is the issue with me?
Yeah, thanks. So if I just respond to that one quickly, no, the numbers absolutely are right. Although my understanding is that during some of the COVID pandemic that reporting of serious incidents did decrease slightly. I don't know if UHL was one of those sites, so I would need to check about that. But in some ways, it's a good thing that reporting is back at the levels that we would expect. There is a process underway, so it wouldn't be fair for me to say, are they absolutely isolated events? There's a lot of work going on between UHL and CCG colleagues, as well as regional improvement colleagues, actually, around where are these numbers at and what is the learning that we can take from them. So that's very much being, the harm review process is being looked at through the Quality Performance Improvement Assurance Committee. And we are absolutely keeping an eye on that, and we can update you as and when that learning comes through. So it is something that's very much on our radar and that we are looking at. UHL have been working as well with a university trust down in London as well, who are seeing very similar positions of reporting. So trying to share some of the learning, what is it we're doing, how can we try and absolutely improve this position and look at patient harm as well. So it's very much coming at it from as much intelligence and learning as we can get. And I can make sure that we keep this committee up to date with where that's at, if that would be helpful.
Thank you very much. Kate, you've got your hand up, I think.
Yes, yeah, it just relates to one of the comments in terms of the number of patients on waiting lists. So I know we've quoted about just around 75,000 County and Rutland patients that were waiting at the end of October. Now that includes patients that right from the point of referral. So some of those patients will only have been waiting a week. So the national target is that we look at those that have been waiting over 18 weeks, because the target is that 92% of patients should be treated within 18 weeks. But obviously we're now looking at the kind of the back end of that graph, that, you know, those that are waiting a lot longer, the 52 and the 104 weeks. So just wanted to give a bit of context in terms of that 75,000. That's all waiters from 1 week beyond, well over 2 years. So just wanted to mention that, really.
Okay, thank you very much. I think that's probably been mentioned actually in a previous session about the overall numbers and what it means, but it's a useful point to remember. Thank you. Okay, can I ask the team on the screen? Are there any other points in the paper that you want to raise? I think there are still a few bits in relation to public health, but yes, public health outcomes. Do you want to
yes,
cover
I've
those?
got to say a few words. I didn't want to say too much because members were quite right earlier in the meeting that we have made the links between the data analysis and the new health and wellbeing strategy. So a lot of work has gone on looking at the data through various lenses and feeding into Viv Robbins and the health and wellbeing strategy team. So that's really shaped some of the priorities, or a lot of the priorities that have gone into that document. So the work it's set out in Appendix 3 is our current framework for looking at public health. There's a wide range of data for public health. We've chosen 38 indicators that relate to the current health and wellbeing strategy and some of the key priorities in terms of service interventions through public health services, and that's set out in the dashboard. And generally speaking, Leicestershire's outcomes are positive for a lot of those areas, but notwithstanding, there's still a lot of targeted issues even within those areas that the services are still sort of working on, health inequalities related and other groups. So in paragraph 23, we just mentioned some of the indicators, 5 particularly ones that have seen some progress over recent time periods, particularly around prevalence of overweight, obesity amongst children aged 4 to 5, cancer screening coverage for bowel cancer aged 60 to 74, and also for cervical cancer, a new STI diagnosis, excluding chlamydia, shown some good improvement over the last periods, but also 2 areas that have been issues for a while around cancer screening coverage for both breast cancer and cervical cancer because of sort of some of the recruitment difficulties around that particular area, and IT systems have seen some declining performance. So that's reflected in the data as well. You did mention life expectancy earlier in the meeting, and just paragraph 24 just confirms the latest figures that have come out both locally and nationally that the pandemic has resulted in a decrease in life expectancy, 0.4 years for males and 0.2 years for females, similar to nationally. So that is very unusual. It's generally been an increasing pattern over many years. So for the first time, we've really seen that reduction. And we are expecting some more data out around healthy life expectancy still to be published, or certainly and health inequalities, which we'll certainly bring back to you in the next report. Just to mention under 18 conception rates, Leicestershire's seen some really good progress over the years on this metric, but just to note that in 2019, for whatever reason, there was a slight increase, so that's sort of one to we've got a bit of a watch on, but certainly better than many areas, so not particularly concerned on that. And then 2 red indicators flagged in the report: smoking status at time of delivery, I think we flagged before, and chlamydia detection rate. So some of that work's fed into the strategy. And then just finally, the Better Care Fund, just to mention to the committee that a new Better Care Fund plan was submitted to the NHS towards the end of November, and it does change the performance targets and metrics a little bit from the previous plan. So I set out in paragraph 31, there's 5 metrics still, but now the focus is on length of stay in hospitals over 14 days and over 21 days. Also, admissions to acute hospitals from the normal place of residence, that's still maintained. Reablement still been maintained, but a focus now on unplanned admissions for chronic ambulatory conditions is included, and I've set out in paragraph 31 the different targets. So we will be bringing some reporting around those moving forwards. Paragraph 32 and 33 set out the latest data on 2 of those metrics. The other metrics are still to sort of come through the system. One of them's going well, reablement still going well. 91.8% against a target of 85%, still at home, so very good reablement services. But some of the demand pressures in the social care do seem to be coming through post sort of the second wave of the pandemic and over the summer. It does look like there's been more admissions to permanent residential and nursing care than the target. So forecast at 550 at the moment. So some of the pressure is starting to play out in the system. So that's all I wanted to say, Chair, just on those sections, but certainly happy to try and take any questions on the detail.
Okay, thank you very much for those. Actually, some of the figures are, I mean, looking back, it will be fascinating to see the sort of 2-year period of the pandemic, understanding the links between things like, for instance, smoking rates not going down, unplanned pregnancies under 18, chlamydia slightly going up in a sort of a particular age group, and some of those may actually be directly linked to the slightly unusual position we've been in for the last 2 years, and maybe we'll revert back to the norm before. And I guess the life expectancy statistically is not surprising, given the excess death rate caused over the last 2 years. Is bound to have a significant, in relative terms, significant statistical change to life expectancy figures. So, but hopefully, the norm will return soon. Mike.
Yeah, thanks, Chair. That was going to be my comment. Andy, it's probably a conversation for me and you outside the meeting, but I was looking at those figures thinking the time period, some scare me. So life expectancy feels like it's going down, but actually that's 2018 to 2020. So we haven't seen the full effect of COVID reflected in those. Some of those, like smoking at time of delivery, is based on 20 to 21. So part of me is trying to work out how much of that is a recording issue to do with staff issues during COVID and redeployment. So I don't want to do a huge piece of work, but actually there's a bit of prep from what the chair was saying. Probably do need to make some note of which ones are kind of currently affected by COVID in the timescale and which are yet to feed through into the performance report.
That's a really good idea, Mike. Yes, yeah, more than happy to have a look at that with our lead analysts and see if we can look at getting behind some of the figures and understanding those sort of impacts. Yeah, that's really helpful.
I'm assuming even going down to, I mean, the 2018 to 2020, I mean, depending on precisely when in 2020 the cutoff was. I mean, if it was May, then actually there was a large chunk of that which would be taken into account. I was just thinking, Mike, actually, this is almost 2 years exactly. It was this meeting 2 years ago that you and I had a discussion about the fact that I was having my first meeting with Loughborough University to discuss China and coronavirus. If you can remember the conversation we had at the end of that meeting, because I had to leave early.
I do, actually. And it was March the 6th was the first confirmed case in Leicestershire. So there we go.
Yeah, January 2 years ago. Good grief. Right. Okay, Amanda.
Thank you, Chair. Just really quickly on Appendix 3, there's obviously lots of data in here where the time period is now quite a long way away. It'd be really useful for us to understand when new data is expected. Because obviously the utilisation of outdoor space for exercise and health reasons is March 15 to February 16. I would imagine that's improved massively. I mean, Mr. Johnson all gave us a permission to go out daily, so we're hoping to see that reflected in the figures maybe. But some of that is still quite, this data is a few years old, and I didn't know when is new data expected. And I'd be remiss, it's my annual plea to Mike about, again, another null bit of information on breastfeeding prevalence at 6 to 8 weeks. We've identified that as being something in our strategic plan, but we're unable at the moment still to measure it.
Okay, thank you very much. Mike?
Andy, I'm just thinking, it's not similar to Boris Johnson, he knows not what he says. I was going to say, Andy, I don't think it's so much that there's no data available, it's just it's still to come through, isn't it? It's the time lag on public health data, unless you tell me otherwise.
Yes, there is a structured, very, very structured national process for data releases, which does have sometimes a sort of a frustratingly long timeline from our perspective as to what we can bring you, when we can bring you it. So I do understand members' frustration at some of the data, some of it for very good reasons. Some of it is obviously does have longer time lags in terms of the construction of the data. But the system is getting better. I'm seeing lots of data groups and intelligence flows and resourcing that's coming through. So I think moving forwards, we're going to have a much sort of more agile system. So I think that will improve. We certainly do have a team that focuses on all of that, on all the data release dates and crunching the numbers when they come in and making sure that's made available to you. And certainly when we construct the new dashboards and data flows, again, we'll be very mindful of trying to bring in the key intelligence as quickly as we can. And trying to improve the system. But I'll only take the points. Yes, some of the data does look quite old. And we'll try and supplement that with better data if we can.
Okay, great. Thank you very much. Look, thank you very much for the three of you for answering questions and for some of the additional information that, in addition to what was actually in the report. Clearly, hopefully, we're looking to see what the recovery does to some of these performance figures. Some already in the report are better than others, but clearly some of those that are sort of CCG related or ICS related, as they will be, are more concerning. To add my own little snippet on some of the figures, the urgent care centre in Loughborough, I spent 2 hours out on Monday morning with my son, who had managed to self-inflict an injury on one of his fingers, and he was seen, x-rayed and treated, and we exited the building with under 2 hours. So I have to say that the 4-hour target is not surprising. 91% is shown as being under 4 hours. It was incredibly efficient. All credit to the team there at Loughborough. It worked. So really impressive. So look, thank you very much to the three of you, and we're now going to move on to the next item. Thank you.
Thank you.
So the next item is item 11, which is our commentary against the quality accounts. There's been a report put together by Ewan, who's our Senior Democratic Services Officer, that supports this scrutiny committee. Obviously, you've all seen the report. Hopefully, the summary is very clear. Ewan has made a very succinct recommendation, which is that we carry on with the process that we already have initiated, which is basically that the summary reports are prepared by Ewan in collaboration with myself, the Vice Chair, and the two spokesmen, and that those are returned through the Chief Executive's office. Ewan, is there anything else in addition that you'd like to add?
No, I think you pretty much summed it up there.
Thank you very much. Stuart.
Just happy to move that, Chair.
Well done. In that case, I'm happy to say if everyone's in agreement, we'll carry on as we are. Everyone's in agreement. Okay, thank you very much. So now move on to item 12, which is the date of the next meeting. That is programmed to be 2 p.m. on Wednesday, the 2nd of March. So look, thank you very much. We have no other business. So I am happy to close this meeting at 5 to 4. Thank you very much. Goodbye.